Hello, everyone, and welcome to our weekly Multi-Modality Imaging Conference here at Houston Methodist Hospital. And so today we're going to follow off where we left last week with a continuation of some presentations from our advanced cardiovascular imaging fellows that will be graduating this year. So today I'm very pleased we have three speakers, Dr. Alpana Senapati, Dr. Shaden Khalaf, and Dr. Roosha Parikh. And let me start off with Alpana, who's going to present first. So Alpana came to us after doing her internal medicine at Cleveland Clinic and did her cardiology fellowship here at Houston Methodist, and has been with us for the last 2 years doing multimodality imaging. And Alpana will be departing from Houston, I think, shortly, and heading out to Salt Lake City, where she'll be joining the group in Utah. So Alpana is going to present to us on CMR in valvular heart disease. Is it the new non-invasive biopsy? So Alpana, please take it away.
Thank you, Dr. Shah, and thank you for everyone for joining us. Let me get this started here. So today I'm going to talk about cardiac MRI and valvular heart disease, and is this really the non-invasive new biopsy? And so overview, I'm going to talk about the CMR basic concepts in valve disease, anatomy and quantification, CMR role in remodeling, cavity and tissue remodeling, comparison to histopathology, and the prognostic implications in valve disease. I'm going to highlight some of the new latest research that's in this field, and also talk about some of our new research developments that we have going on. So as we all know, cardiac MRI has great spatial and temporal resolution, where we're able to clearly delineate valve anatomy. So on the top, you have a patient with Barlow's or bileaflet mitral valve prolapse, on the bottom with bicuspid aortic valve, and you can thoroughly interrogate each of the valve leaflet and cuffs to determine basically what's going on with the valve and the valve anatomy. So cardiac MRI also is basically a gold standard for the non-invasive quantification of volumes using end-diastolic minus end-systolic volume over the end-diastolic volume would give you the EF, as well as flow quantitation, where you can essentially get flows through the aortic valve, pulmonic valve, getting systemic and pulmonic flows, and the LV and RV stroke volume. So this way you're able to quantify regurgitation or stenosis by anatomic valve area by a variety of methods in MRI. So it gives you a great overview for valve anatomy as well as quantification. So what's new in cardiac MRI is due to the latest advances in cardiac MRI with faster imaging processing, we're able to now look at myocardial tissue remodeling and also ventricular remodeling. And so we know that chronic valvular heart disease leads to changes in the ventricular cavity remodeling, as well as LV myocardial tissue remodeling, which then leads to two different forms of myocardial fibrosis. Regional replacement fibrosis, that's measured by LGE, or late gadolinium enhancement, and diffuse interstitial fibrosis, that's measured by ECV, which is extracellular volume fraction. And then this allows quantification of LGE and ECV in a non-invasive manner, similar to biopsy, and this has shown to have good histopathologic validation, and obviously has prognostic implication, which I'll show you a couple studies that's been out there on this. And as we know, the myocardial space is a complex dynamic process composed of myocytes, cardiomyocytes, fibroblasts, as well as the cardiac interstitium, which is made up of collagen matrix, as well as the capillary network, which makes up typically in normal patients about 25% of the myocardial structural interstitium. And in the bottom figure, you can see that there's good histopathological correlation. This particular study looked at an animal model involving dogs. And what they found was delayed enhancement, contrast enhanced MRI has good histopathologic validation on autopsy results. And as you can see, the white is scar, and it's pretty much almost an identical scar pattern when you do slices through the heart in an autopsy dog model. So what do we know about the latest guidelines? So we know from the latest guidelines that, it's great for, patients that, meet the cutoffs and decision to intervene on the valve. But as we know, a lot of our patients don't really fall within these guidelines, whether they have moderate MR or moderate AR, and they're symptomatic. So, the guidelines are based off of symptoms and echo-derived 2D measurements and quantification. So, where does MRI have a role in all of this? So we know that MRI has a value in quantifying aortic regurgitation. This particular study looked at 113 asymptomatic patients with moderate to severe aortic regurgitation that was quantified by echo and followed for about 9 years. And what they found was out of those, 39 patients underwent aortic valve replacement and became symptomatic later on. And then what they found was discriminators for future need for AVR was at lower thresholds than previously established echo guidelines for regurgitator fraction, which in this case by MRI quantification would be regurgitator fraction more than 33%, and LV and diastolic volume of 246. So what this shows is quantification of aortic regurgitation with MRI showed a significant associated with the symptoms and future need for aortic valve surgery. And so this potentially has a role for identifying at-risk patients or asymptomatic patients that will eventually progress to need aortic valve replacement down the road. And similarly, the same group looked at patients with quantifying mitral regurgitation. And what they looked at was 109 asymptomatic patients with moderate to severe mitral regurgitation that was noted on echo, and they followed the patients up for 8 years. And 25 of them became symptomatic and needed mitral valve surgery. And what they found was the future discriminators for need for mitral valve replacement was a regurgitator fraction of more than 40% by MRI, and also a volume of more than 55, and also having indexed LV and diastolic volume more than 100. And so similarly, like the AR population, we know that from the MR population that we are able to maybe identify at-risk patients that will go on to need surgery or valve intervention down the road. And so what does this tell us? So this tells us that at lower thresholds than previously realized for regurgitator fraction, we know that patients become symptomatic. And so this tells us maybe we're waiting in some of our patients too late to intervene on the valve. And so I think this is where the role for fibrosis assessment with contrast enhanced MRI comes in. And as we know, there's two types of myocardial fibrosis. There's replacement fibrosis, or LGE, which is basically irreversible damage. And then there's diffuse interstitial fibrosis measured by ECV, which is a dynamic process. And so both these techniques involve the use of gadolinium, which is the extracellular contrast agent. And by using novel T1 mapping techniques, we're able to detect and quantify the amount of myocardial fibrosis by measuring the retention of gadolinium contrast agent in the myocardial tissue. So we do a pre-contrast T1 map, give the gadolinium, wait about 15 minutes or so, do a post-contrast, get an ECV map, and by using the equation by correction for hematocrit, we're able to determine the ECV, or the percent fraction of the myocardium that's taken up by the extracellular space. And so this has prognostic implications for replacement fibrosis in MR. We know this is out of Dr. Shah's group, actually. What they found in this population with mitral regurgitation is they compared two groups, mitral valve prolapse patients and non-mitral valve prolapse patients, in 356 total patients. So what they found was those with mitral valve prolapse, regardless of the amount of regurgitation that they had a higher incidence or prevalence of having replacement fibrosis, and this is mostly located in the basal and lateral segment, and that this was associated with a higher event rate for arrhythmic events down the road. And so this tells us that there's prognostic implications of replacement fibrosis also in severe aortic stenosis. This particular study looked at all-cause mortality and cardiovascular mortality in about 670 patients with severe aortic stenosis that were undergoing valve intervention. And out of those, you see that those with having replacement fibrosis did poorly as opposed to those who did not have replacement fibrosis. And this was a median follow-up of about 2.6 years. And we also note that the type of infarct is also important. And so those with the infarct, a subendocardial infarction pattern, as opposed to a non-ischemic infarct pattern, tend to do worse. And so what they found was the if you had replacement fibrosis, the predicted all-cause mortality and cardiovascular mortality increased. And this is also regardless of intervention, whether the patient had a surgical AVR or TAVR valve, and that having LGA that was positive was a 2-4 higher risk for late mortality in these patients. And also what we know that there's good histopathological validation with the CMR ECV, and several studies, including these two, looked at amount of collagen volume fraction by histopathology as well as CMR-derived ECV, and that there was good correlation between the two, and the gold standard obviously being the LV biopsy. And so, this is important because this tells us that the myocardial space is divided into 2 compartments, and also tells us that the LV mass, and when you have an increase in LV mass, that it's not always pathologic, and that it could be physiologic. And this particular study looked at LV mass in athletes and showed that the increase in the LV mass in athletes is primarily due to cellular hypertrophy, whereas in hypertrophic cardiomyopathy, it's due to extracellular matrix expansion. And on the right-hand side, you can see that high-performance athletes have a higher LV mass, and this is primarily driven by the higher index intracellular mass, but as opposed to a higher or increased expansion of the intracellular space. This is important because it tells us that the extracellular matrix is a dynamic process, and the LV mass is also a dynamic process with the interplay between the ratio between the extracellular matrix as well as the cellular mass. And so we know from recent studies that there are 2 CMR biomarkers in aortic stenosis, one being the ECV, which I discussed, and also an indexed ECV, which is essentially the ECV multiplied by the index myocardial volume. And this particular study looked at for about 440 patients with severe aortic stenosis, and also evaluated risk for mortality and heart failure. And what they found was increased ECV or myocardial fibrosis was associated with all-cause mortality independent of age, LGE, and severity of aortic stenosis. And also on the right-hand side, you can see that the amount of interstitial fibrosis increases with the degree of aortic stenosis severity. And so what does this tell us? This tells us that ECV is prognostic in aortic stenosis, not just replacement fibrosis measured by LGE, but also extracellular volume, and that this is a process that takes time to resolve after aortic valve replacement. So initially you have on the right-hand side, you can see that there's a decline in the LV mass, and also the decline in the diffuse fibrosis, which lags behind the LV mass, whereas the replacement fibrosis is an irreversible process. And so we know that from prior studies that ECV is prognostic, but we also know that there's reverse modeling after AVR. This particular study, about 116 patients with aortic stenosis post-AVR, looked at gadolinium enhancement with LGE, but also looked at ECV. And what they found was at post-AVR, there was a regression of LV mass index, but the ECV fraction did not decrease as they expected with the paradoxical increase. This is mainly driven by a higher ratio of the derived cell volume decreasing more than the derived matrix volume or the extracellular volume. And this is important because this tells us that the extracellular matrix is composed of the cell volume and the matrix volume, which is index ECV, and that in these patients post-AVR, that this process can reverse and has potentially can be measured by MRI. And so we know that CMR math allows better understanding of underlying pathophysiology of the myocardial space, and that diffuse interstitial fibrosis is a dynamic process that regresses with intervention, whereas a replacement fibrosis does not, and that this is a potential therapeutic target. And so we know from several studies that there is myocardial fibrosis and aortic regurgitation that has good correlation with histopathology, and that the degree of myocardial fibrosis is associated with poor outcomes in this population. And so with that, we were interested in looking at, because there were so many limited studies, with the previous one being about 50 patients or so, we wanted to look at the regional replacement diffuse interstitial fibrosis, the chronic aortic valve regurgitations we underwent. So we have 2 patients here one where the 84-year-old man who severe aortic regurgitation, and you see the on pre and post map at the top, and what you can see is index ECV in the first case is 28, whereas in the second case you have a 45-year-old symptomatic patient. The first case was asymptomatic, that is referred for cardiac MRI for aortic regurgitation assessment, and you have moderate to severe aortic regurgitation. And what you can see in this case, you have a much higher index ECV of 39%. So can we use this information by MRI and diffuse fibrosis using ECV to help risk stratify these patients who will move on to become symptomatic? So the background for our study was we looked at chronic AR patients. We know that it leads to 2 forms of fibrosis. And we know that there's 2 new biomarkers, ECV and index ECV, and that there's limited data that on the role of these biomarkers in aortic regurgitation. So we went on to perform the study. What we did was our objective was to evaluate CMR biomarkers for myocardial fibrosis in association with clinical outcomes in this population. So we took for consecutive patients with chronic aortic regurgitation with a native T1 map, pre and post contrast T1 map, and we included all these confounding factors, fibrosis and prognosis, and also excluded patients with cardiac devices as they can intervene with the ECV measurements. And our total population was 177. So we looked at cell volume, index ECV, as well as ECV in our population. What we found was index ECV increases with AR severity, whereas the prevalence of LGE was not that high in the population, was only 7%. And the ECV percent fraction actually did not increase with increasing aortic regurgitation severity. And this is likely driven by an increase in index ECV as well as cell volume. And so the ratio kind of balanced out. And what we found that the characteristics associated with the composite event of death and AVR were the 2 composite events that we looked at, was index ECV when adjusted for multiple risk factors remained significantly associated with the composite outcome. And here, when we further risk stratified and dichotomized the index ECV, we found that those with a higher degree of aortic regurgitation severity and those with a higher ECV, more than 24 in this case, did poorly and met the composite event of death or AVR. And so what does the study show? The study shows that, patients with chronic aortic regurgitation undergo myocardial tissue remodeling, which can then be assessed by MRI, and that there's 2 new biomarkers that are present, and that index ECV in this case is better predictor for outcomes versus ECV and LGE, which is in aortic stenosis, as you remember, ECVs and LGE were prognostic in this case. And we know that MRI can provide additional prognostic information for clinical outcomes, but we need future studies to confirm the clinical significance of these biomarkers in the population. And so we know that cardiac MRI is a versatile tool, and that using tissue myocardial characterization will continue to improve stratification, and that the future is really we need an individualized approach and use for multimodality imaging for individualized therapy, and is ECV a biomarker that can be used as a potential therapeutic target. There's a couple of studies that are coming out, one being an EVOLVE trial looking at asymptomatic aortic stenosis patient and use of cardiac MRI biomarkers in the population. So stay tuned for more research in this area. So thank you, everyone, and I'll be happy to take any questions.
Great. Well, Alpana, that was a fantastic presentation. Very nice overview of the topic, as well as a little overview of a project that you worked on yourself. So let me ask you, and I think you kind of touched a little bit on what next steps are, but let me probe you a little bit further on that. And I guess someone could ask the question. Can you hear me?
Yeah.
Oh, okay. Sorry, you were cutting out there for a second. I guess the question would be is do we use, in other words, do we think of it as this fibrosis or this alteration of the myocardium that's happening? Is it directly tracking the valvular regurgitation or the valvular stenosis? Or is it maybe a kind of a summated measure of all the insults that are happening to that patient, including the valvular lesion, but also maybe coexisting hypertension, diabetes, or whatever else. And I guess what I'm trying to get to is the differences you're seeing between different patients, is it because different patients are responding differently to valvular heart disease, to differing severities of valvular heart disease, or is it that it's a combination of everything else that's going on in these patients, but it's a net effect?
Yeah, I think that's a great question. I think, obviously.
Yeah. Thank you. We don't need it anymore. Thank you.
Clinical, looking at the whole patient, I think it's important that hypertension, diabetes, all these also contribute to having diffuse interstitial fibrosis. And our population and some of the aortic stenosis population, if you adjust for some of the clinical risk factors like CAD, hypertension, diabetes, I think some of it is also driven by the severity of the valve lesion itself. Now, what does that mean clinically for the patient? I think clinically for the patient, we can't really say, hey, we're just going to ignore the diabetes and the hypertension, but we're going to have to look at the MRI and the biomarkers as a whole. And I think it's going to be an additive effect, in my opinion, and that, having severe valve disease and hypertension, diabetes in a patient with moderate MR or moderate AR may be more clinically significant than a patient who has severe AR and probably has no hypertension or diabetes. In the two cases that I showed, the first case had well-controlled hypertension. It's a much older guy, 84 years old, versus the second case, who was a 45-year-old guy, had hypertension as well, but had a lower degree of recurrent refraction, was more symptomatic. And so what was driving that? I think some of it's also with the underlying fibrotic pathways that get activated in the patient, but I think the combination of risk factors definitely is the additive insult to patient.
Great. We've got time for maybe one more question. Is there any other questions from any of the folks?
I have a question.
All right, Steve.
The use of the term biomarker for this. So we tend to think of biomarkers as, a distant measurement, right? It's, troponin or BNP, you're measuring it in the peripheral blood from something that happened somewhere else. This is a direct imaging finding in the chamber that's being directly affected, whether primarily or secondarily by this AI. So, it's unusual to call an imaging finding a biomarker. How do you get to that? Because it's a little analogous to saying, LV hypertrophy and AS. Is hypertrophy a biomarker? Would we use it that way? And is this different than that?
Yeah, I think that's a great point. I think, ECV, as we know, it's a surrogate marker for the amount of interstitial fibrosis. So if we're calling interstitial fibrosis a biomarker, I think you're right to say it's not really a biomarker. It's not coming from the blood itself, but it's not a direct measurement of interstitial fibrosis, but instead it's a surrogate marker. So yeah, point well taken. I think it's more of an imaging marker for rather than a biomarker in the true sense.
Okay.
It could be. I could see your point, Steve, that traditionally biomarkers are serological or something, right? That's something that you draw that tells you something, a parameter, an index. It's still biologic in a way. And maybe the others should be more clarified. Immunological marker, serological marker, imaging biomarker, whatever it is, it's an index.
Great. Well, Alpana, that was a fantastic presentation. Thank you very much.
Thank you.
We're going to move on next to Dr. Shaden Khalaf, who's going to present a interesting multimodality imaging case where imaging is guiding clinical decision making. And before I introduce Shaden, also I want to give an opportunity for any of the folks outside of Houston Methodist that are watching via live stream or Facebook. If you have a question, please text it in to DeBakey or text DeBakey to the number 37607 or go online to pollev.com/DeBakey and ask your question, and we'll be happy to pose any of the questions for any of our speakers today. So Shaden is completing 2 years of multimodality imaging training here at Houston Methodist. She came to us from Cleveland Clinic, where she did her internal medicine residency, and Baylor College of Medicine, where she did her cardiology fellowship. And Shaden will be staying here in Houston and actually joining Baylor College of Medicine to continue her multimodality imaging career. So Shaden, please take it away.
Thank you, Dr. Shah. So today we're going to be discussing multimodality imaging and guiding clinical decision making via case-based approach to a topic from a clinical and an imaging standpoint that's never or often not as clear-cut as we'd like it to be. So without further ado, we have a 70-year-old male who was admitted for progressive weakness, fevers, unintentional weight loss. He had a history of CAD with a remote stent, hypertension, diabetes, and a prosthetic aortic valve in 2016 at an outside hospital. Leading up to the events, he had influenza A a couple of months prior and never recovered. He continued to come to his doctors and came into cardiology, and at that time he had a normal echocardiogram and a really unrevealing outpatient workup, except that his white blood count kept on going up over time and his inflammatory markers, CRP and ESR, kept on going up. So his outpatient echo revealed normal biventricular function. His anatomical prosthetic valve looked good. The hemodynamics of the valve as well looked good. There was no issues there. So now he gets admitted because things are not improving, and on admission he grows 2 out of 2 strep mitis in his blood. His white count is 25,000. He remains afebrile. However, he has subjective fevers. He denied any oropharyngeal or GI procedures which are commonly implicated with this type of bacteria. So his inpatient echocardiogram, as we see here, is demonstrating normal biventricular function. However, his valve leaflets appear to be thicker than the initial echocardiogram I did reveal, as well as the aortic root appears a bit thicker. At the time of the valve or echo assessment, the hemodynamics and the Dopplers were not most pristine. So the overall impression of this transthoracic echo is that there is echogenicity, thickening of the valves, and also this is different from what we saw a couple of months earlier. So a transesophageal echocardiogram was recommended. His transesophageal echocardiogram here shows that the bioprosthesis is significantly thickened. Let's go back to it. Okay, and on a closer look, now the valve doesn't show any destruction or any clear-cut abnormality other than this thickening of the leaflets. And when we take a closer look to the area of the aortomitral curtain here, this region appears to be a bit more thickened than we'd like. We don't have the baseline echocardio TEE at the time of surgery to compare. However, this area is concerning, especially here at the takeoff of the right coronary artery. This area is significantly thickened and concerning for an area of abscess formation. By color Doppler, we don't see any communication there to suggest pseudoaneurysms or fistulization, and there's no regurgitation. On deep transgastric views, where we obtain our hemodynamics assessment of the valve, the PW through the LVOT and the CW through the aortic valve, we're seeing high velocities around 3.8. And our overall assessment here is that the valve is thickened, the root is thickened, along with hemodynamic assessment concerning for valve dysfunction and suggestive of stenosis. The area of the aortomitral continuity is thickened, concerning for abscess formation. However, it wasn't as clear-cut to say, hey, there's a clear-cut vegetation that we saw on TEE. So a CT versus a CT PET was recommended. So when we talk about prosthetic valve dysfunction, this is a nice paper put forth by Dr. Pellica and her colleagues on, it's a statement paper by the ACCHA. When we talk about prosthetic valve abnormalities. We define them as deterioration of the leaflets or supporting structure, resulting in thickening, in calcifications and tears that over time will eventually lead to hemodynamic significant valvular abnormalities, whether it is stenotic or regurgitant. Structurally, it could look like a pannus, calcification, or a tear. Or on the other end of the spectrum, endocarditis, thrombosis, especially in mechanical valves, and paravalvular leaks are things to keep in mind. So this is from the guidelines put forth by our very own Dr. Zogby. When we assess prosthetic valves, we look at various parameters and indices. We don't take one in isolation of the other. So we look at peak velocities, mean gradients, DVI ratios, along with the contour of the Doppler signal and our acceleration time. So in our case, our velocity was 3.8 within this range of possible stenosis. Our mean gradient was high, at 38, and our DVI came out to be at 0.4, which actually falls in the normal range. So a little bit of a hodgepodge, but the overall picture with a high pretest probability for endocarditis, which is the key thing here to keep in mind, makes us think twice. When we look at the graph and the guidelines as well, you know, we're starting out at the DVI of more than 0.3. However, we have an acceleration time that's high, also suggesting some prosthetic dysfunction. Why that is, sometimes we don't get the best alignments of the LVOT, and on TEE, sometimes we don't get the best, we get underestimation of the gradient. So that could be part of the reason there. So clinically, the patient's not doing well. We needed to get an answer. The patient underwent a CV PET, which is inflammatory FDG PET. And what we saw here with a low-dose CT with superimposed PET images on it is through the axial slices, as we go through, aortic valve is coming in. We're seeing FDG uptake all around the root and significant posterior uptake right there, and an area of anterior uptake by the right coronary takeoff. So overall, with our FDG PET, what we found is these findings are very suggestive of endocarditis, of aortic valve endocarditis, with significant uptake within the root, especially by the right coronary cusp and also by the left coronary cusp. More so, we do something what we call SUV, whereby we calculate the standard unit value of uptake of the FDG itself, and it was very high, around 5.7, which is very suggestive of inflammation. The Hounsfield unit on CT of the areas that were of question were also around 30 to 35, which is also concerning for abscess in that region. So the patient was taken to the operating room, and at the time of surgery, there were large vegetations that were loosely attached to the bioprosthetic leaflets. There were 2 abscess cavities visualized around the sewing ring with active pus in that area. One underneath the RCA ostium, the second was by the left coronary cusp and into the mitral annulus and extending actually within the left atrial myocardium. So extensive surgery. He underwent not only aortic root replacement, but a aortic graft and an ascending aortic replacement, and he did very well. So when we look at imaging of endocarditis, we always start with a transesophageal echo. That's the go-to test. In cases of bioprosthetic aortic valves and lead and concern for intracardiac or lead endocarditis, TEE is a must. The algorithm also states even if a negative echocardiogram is present with continued suspicion, you need a TEE to clear out the question. And there are various definitions, and things that could take place. Vegetations, abscesses, pseudoabscesses, perforations, and fistulations can occur. It depends really also on the valve type, what is more likely to occur. So prosthetic valve endocarditis by itself is a rare yet life-threatening condition. It's the most severe form of endocarditis and accounts for anywhere between 10 to 30% of total endocarditis. Less vegetations are seen in prosthetic valve endocarditis. However, we see higher incidences of abscess or paravalvular pathology. It's complex in its management. It's not easy to take a patient for a redo surgery. There's substantial risks at times, and the question of operative timing also comes up. When's the right time? Prevalence of prosthetic valves are on the rise. We're doing a lot more transcatheter interventions, so we're going to see more prosthetic valve endocarditis, so we need to be ready. And then the type of prosthesis, when we talk about mechanical prosthesis, is a bit different from bioprosthetic prosthesis. In mechanical valves, the infection starts usually at the sewing rings, leading into pseudoabscesses, dehiscence of the valve, paravalvular leaks, and so forth, and fistulations. However, with bioprostheses, usually the infection starts at the tips, goes into the leaflets, perforates, and leads to vegetations. It's never clear cut. It could happen in all sorts of orders, but that's what's commonly described. So with every imaging modality, there are common pitfalls. When we talk about, there's nothing that's 100% in life, obviously, and so is imaging. A negative echo does not rule out endocarditis. So repeat imaging, TTE and TEE may be necessary, and it really is individualized depending on the context of the pretest probability. The sensitivity and specificity of both TTE and TEE are reduced in prosthetic valve endocarditis and those with intracardiac devices. So early imaging, repeat imaging per the guidelines, delineating thrombus from vegetations can be super tricky at times, and early post-operative changes are a big challenge because it's hard to tell whether or not that's just post-operative thickening, especially early on from infection or abscess formation. But it's always nice to have a baseline TEE from the operative room to compare when the question of endocarditis arises, because you can then compare a bit of apples to apples, which we didn't have that in this case. So multimodality imaging for endocarditis, echo first, we always stress that. However, ancillary roles for other imaging modalities such as CT in detecting prosthetic complications is on the rise and helpful. Assessment for the extent of abscesses or pseudoabscess formation. It can be an alternative for mechanical valves to assess for motion, leaflet motion. It has been used for cusp assessment in biological valves if the other imaging modalities are inconclusive. There is some talk about using CTA and CT to assess for low-risk patient going for coronary artery assessment as opposed to cathing, especially where there is a large vegetation sitting on the aortic valve. So this is just an example of how a pseudoaneurysm just below the bioprosthesis here is communicating. The bioprosthetic valve has lost that tissue delineation here, and what we're seeing is that the valve is a bit tilted, concerning for prosthesis dehiscence and pseudo abscess formation in this person. And moving on to PET, or positron emission tomography, that we use in this case, it's on the rise and has been very useful in cases of suspected endocarditis. And the greatest, or the largest registry is the European Infective Endocarditis Registry, which demonstrated that this modality's use is on the rise, about 17% for the total cohort of their patients. And that in prosthetic valve endocarditis, it's being used as an adjunct in 25% of cases, and so for device-related endocarditis. The accuracy of FDG PET ranged from 67% to 28% in native valve endocarditis. It doesn't do very well in native valve endocarditis, and it's actually ill-advised due to high rates of false positive rates there. However, when we add the PET data to the modified Duke criteria for assessing for endocarditis, the diagnostic sensitivity improves significantly from 70 to 97%. So the main limitation there is FDG PET has a high false positive rate. Valve thrombosis and early postoperative changes are very challenging for this modality as they are for others. In this modality, we need to really suppress the physiological myocardial glucose uptake, so that requires the patients to be on a low carbohydrate diet for 24 hours, followed by a 12-hour fast. And the premise here is that with inflammatory assessment with PET is that inflammatory cells such as macrophages and leukocytes really like glucose. They use glucose as their preferred energy source. So when we give them a FDG, which is a radio-labeled glucose, this form of glucose gets trapped in the cells and they do not undergo glycolysis. So it lights up when we image them. The imaging time is pretty short, 10 to 20 minutes. We use hybrid imaging with CT, a fusion technique where the anatomical images are defined with CT, and we superimpose the PET images to delineate which areas are involved. And any area of FDG uptake is a concern for active inflammation versus infection. Moving on to indications for surgery, as per the American Thoracic Surgeries Guidelines, there's a Class 1 indication for valve dysfunction resulting in symptoms of heart failure, and another Class 1 indication to take these patients to the OR is left-sided infection, similar to native valve endocarditis with Staph aureus, fungal infections, or virulent organisms that are highly resistant. Class 2A indications are for relapsing infections, recurrent emboli, persistent vegetations despite appropriate antibiotics. So this is actually a really nice study put forth by the Sweetheart Group. It's the largest registry that we have today, about 26 plus patients who underwent prosthetic aortic replacement in Sweden, both mechanical and bioprosthetic. And the incidence of this disorder is pretty low, thankfully, given the devastating consequences of it at times. In mechanical valves, it's less prevalent than it is for bioprosthesis, on the order of 0.5 percent per year for these patients in mechanical valves, and a little bit higher in bioprosthetic AVRs at 0.7. The incidence of endocarditis is highest the first year out of surgery. In another recent article from the Cleveland Clinic's experience with prosthetic valve endocarditis lists 529 patients. The majority of these patients, they looked at the cohort of patients who went to redo operation versus conservative medical management, as they were deemed non-surgical candidates initially on first assessment. And those who received non-surgical treatment alone fared a lot worse, actually. There was increased rates of survival at 1 year mark and thereafter, increased rates of readmissions and heart failure readmissions as well. So the conclusion of this study came to that the surgical treatment is associated with a very large survival benefit in prosthetic valve endocarditis. And if we pursue a medical option for some of these patients, it really is imperative to follow them very closely as they can develop complications quite frequently, and they may get reoperated on if they were deemed a bit maybe more stable. So with that, I open it to questions, and really thank you for giving me this opportunity today, and for the past 2 years, thank you to all our attendings, co-fellows, and staff here at Houston Methodist.
All right, wonderful presentation, Shaden. We've got time for a question or two. And while we're waiting for any questions from the audience, let me pose a question to you. So you're, a month from now or 6 weeks from now, you're a faculty, and you get called. I've got a patient that I'm concerned about endocarditis, and I know you start off with the algorithm echo first, which I think we would probably all agree with. Now the question, I guess, in the current pandemic setting, would you still proceed to a TE first with concern of aerosolization, or would you modify the approach that you take in this setting? Obviously, nobody knows the right answer here, but I'm asking, what are you going to do? Because you'll get this call. I'm sure,
Yeah.
in a month or two?
It's a very good question, and I think the bottom line and the first step is if I have appropriate PPE for the staff and the people involved, I think TEE is the way to go. And we can assess for vegetations, we can see valve destruction pathology. If there is no PPE, then other imaging modalities, everything has their own pitfalls, right? Echo does, CT does, PET will do in this situation. Then a second approach, but hopefully we'll all be protected and we have PPE and we'll get through it.
Yeah,
Yeah.
I think it just kind of highlights the importance of understanding all your different modalities
Correct.
that you have, and in each scenario applying which is going to be the best test for the particular scenario. I think Bill, do you have a question also? Or comment?
No, I think that's a very important question. I think timely in the COVID era, and there will be some recommendations coming out hopefully in the next few weeks. But I think, Shaden, you got it right. There are situations where you still have to go for your best methodology, particularly if the vegetations are small and mobile. I think this is where some of the issues may occur with other modalities like CT or MRI. You may have artifact from the modalities, and at times you may have to combine them. Just like in this case here, just thickening alone may not give you the diagnosis. And I think PET was I wouldn't say essential, but very important, because clinically, right, you had a suspicion and a diagnosis for bacteremia and most likely endocarditis. But here it really focused where the inflammation is, and it helped you significantly. So, at times you may have to use more than one modality to come to a clearer diagnosis.
Yeah.
Great. Well, thank you very much, Shaden. And we're going to move on next to our next presentation. And this is by Dr. Roosha Parikh. And Roosha also has been with us for the last 2 years doing multimodality imaging training. Roosha came to us via Cleveland Clinic, where she did her internal medicine, and via Mount Sinai Hospital, Beth Israel in New York, where she did her cardiology fellowship. And Roosha will be going back to New York after this to join the St. Francis Heart Center. So Roosha is going to present an interesting structural interventional imaging case of a reverse Lampoon procedure. So this will be interesting for me as well, since I've never seen this. I'm looking forward to it. Roosha?
Thank you, Dr. Shah, for the introduction. So I'll go over my case of the reverse Lampoon. Lampoon stands for intentional laceration of the anterior mitral valve leaflet to prevent left ventricular outflow obstruction, assisted TMVR. So briefly about this patient, 82-year-old frail woman with a past medical history of hypertension, hyperlipidemia, prior stroke, atrial fibrillation, mild CAD, with the surgical history of mitral valve replacement 4 years prior in 2016 with a bioprosthetic 25mm Carpentier-Edward Perimount Magna East valve, having frequent heart failure hospitalizations with NYHA class 3 symptoms. I'll go over her imaging findings and focus more on the structural, interventional, procedural imaging in this case today. So she was found to have severe bioprosthetic mitral stenosis with a mean gradient of 20 millimeters mercury at a heart rate of about 75 to 85, moderate to severe mitral regurgitation. She had pulmonary hypertension with the RVSP of 55 to 60 millimeters mercury, a neo-LVOT area of 180 square millimeters, which we'll go over. So this first image is a baseline cardiac CT that was done for TMVR planning with the phases from 20 to 80%, and reconstructed a view similar to our typical echo 3 chamber. Here we can appreciate an enlarged left atrium, a bioprosthetic mitral valve with thickening, and restricted opening of the leaflets. We can also appreciate that the anterior leaflet of this mitral valve causes some obstruction along the LVOT in systole. The second video shows a reconstructed image through the mitral valve leaflets of the bioprosthetic valve at the base of the heart, and we see that the leaflets are thickened with stenosis of the bioprosthetic valve leaflets. So this is a reconstruction of the CT on a special post-processing software which demonstrates where the new valve would be placed in mitral position, and also the neo-LVOT post-valve deployment, which had an area of 183 millimeters. Some of the approaches that may be considered next for this patient would be alcohol septal ablation in cases where there's a prominent septum, so that the size of the basal septum could be reduced and increase the size of the neo-LVOT. However, for this patient, the septum was already normal in size and not very prominent, and the patient was not a candidate for alcohol septal ablation. So here, a valve-in-valve approach becomes difficult. So based on this measurement by the CT, we chose a reverse Lampoon assisted TMVR, which is a tip-to-base laceration of the anterior mitral valve leaflet to reduce the risk of LVOT obstruction, which is associated with the high-risk mortality. These cases are typically proctored by an expert. So the first image is 3D TE image of the mitral valve. These were all intra-op TEs. On the left, you can see that the bioprosthetic mitral valve with the 3 leaflets are thickened with evidence of stenosis. The right image shows the addition of color to the 3D image and demonstrates at least moderate mitral regurgitation visualized in systole. And during diastole, you can see that there's flow acceleration suggestive of significant stenosis. This is the baseline mitral valve gradient of 11 millimeters mercury. This was at a heart rate of 67 beats per minute when the patient was under general anesthesia and intubated. This image is a 3D TE view of simultaneously seeing the left atrial aspect and the left ventricular aspect of the mitral valve. On the left side, the aorta is at the 12 o'clock position, and on the right image, in the ventricular view, the LVOT is at the 12 o'clock position. Again, we can continue to appreciate the bioprosthetic mitral valve with the thickened leaflets and restricted opening. Next, we move on to the procedural steps performed under the TE guidance. The first step was the transseptal puncture that was performed with the mid-esophageal 4-chamber view, typically at 0 degrees, and then explaned through the point of interest, which would give us a view similar to the bicaval. Here, the transseptal puncture was performed at 3.3 centimeters. Typically, the transseptal puncture for this procedure should be performed mid-fossa more posteriorly, at least 3 centimeters above the annulus. The location can be confirmed on 3D if needed, and here we have a 3D image where we can see the needle come across the fossa. Here we have images, the 3D views of the mitral valve with the equipment across. We have the Gillis sheath, the steerable catheter across the septum and going through the mitral valve. Next is the RAO and LAO fluoroscopic images during the laceration. So after the transseptal puncture is performed, the Agilis catheter is positioned, and then a balloon wedge end-hole catheter was floated through the mitral valve prosthesis, then through the LVOT, the aortic valve, and into the aorta. The purpose of the balloon wedge catheter is to protect the subvalvular mitral apparatus. After that, you have a stato wire, which is focally denuded and kinked mid-shaft to form a flying V. I've tried to point out the flying V while it is inside with the blue arrow. So this flying V is formed externally, and then the wire is brought up through the steerable catheter and positioned at the offending bioprosthetic valve leaflet tip using TE and fluoroscopy. The guide wire is then pulled towards the bioprosthetic valve ring and electrified, so cauterized at 70 watts with continuous flush. So there is no significant burning otherwise. And the wire, the flying V, captures the leaflet from tip to the base and slices the leaflet. The surgical ring of the bioprosthesis then prevents the extension to the aortomitral continuity. So this is the laceration and the flying V technique. This is a 3D TE image captured during the laceration of the bioprosthetic mitral valve leaflet. There's limited visualization when the cautery is being applied, and we essentially see bubbles and infusion of the D5 saline. But we want to make sure the equipment remains in a stable position anteriorly. So here we see X-plane images of the bioprosthetic valve leaflets that's been split, causing a flail appearance. On the left side, we have the 2D images, and on the right side, we have color added. We can now see severe iatrogenic mitral regurgitation, again, confirming that the intentional laceration was performed. Next, we have 3D images showing the Edwards Sapien 3 26 millimeter valve being deployed across our bioprosthetic mitral valve. This happened with rapid pacing of the RV. This is the final image of the valve in the mitral position. We see that the leaflets are opening and closing normally, and there's less than trace residual mitral regurgitation. The mean transmitral gradient was 2 millimeters mercury at a heart rate of 70 beats per minute. The important thing here is to look at our LVOT and aortic valve gradients. So the image on the left shows the final post-procedural CW Doppler through the aortic valve in the deep transgastric view during TEE. The peak velocity is under 1.5 meters per second, and the image on the right shows the final post-procedural PW Doppler through the LVOT, again through a deep transgastric view. And the peak velocity here is also under 1.4 meters per second, which shows that there is no significant obstruction across the LVOT. This is an image showing the LV-gram that was performed to assess for residual mitral regurgitation, again confirming already what we saw on echo, that there was less than trace MR. An iatrogenic ASD was noted at the end of the study, as we had gone through with the transseptal puncture, and there was flow that was left to right, and this was not closed. The routine practice at our institute is to only close right to left or bidirectional shunts. And this is an image showing the final transmitral gradient across the valve in the mitral position with all the equipment removed. The final mean gradient was 1 millimeter mercury at 66 beats per minute. And the patient did well and was discharged the following day. So in summary, this is a tip to base, which is referred to as reverse Lampoon, which prevents bioprosthetic leaflet LVOT obstruction before valve-in-valve TMVR. In native valves, the Lampoon is performed from base to the tip to avoid the inadvertent laceration of the aortomitral continuity, requiring the traversal of the base of the A2 scallop, which can be technically challenging and time-consuming. By contrast, the tip-to-base Lampoon involves lacerating the leaflet from the tip to the base using a simple veno-arterial rail with the surgical ring of the bioprosthesis preventing the extension into the aortomitral continuity. And with this, I'd like to thank the whole team who participated in this case, with a special thank you to Dr. Little and Dr. Sachin Goyal. And thank you, Dr. Shah, for letting me be a part of this program.
Right. Well, great. Well, excellent presentation. So that's, I have to say, first time I've seen that case. So it's always nice to see something new. Let me ask you, we'll take a question or two from the audience. I know one of the things is, what's the duration of a procedure like this? And then the second question is, I know traditionally the layout of the OR, I've heard Steve Little say this many times, is the interventional imager is the one who's sitting right next to the radiation source. And have they reconfigured the rooms a little bit to try to be sensitive to the fact that these are long procedures and try to minimize radiation exposure for everybody?
So this specific case was 3 hours long. It was in the OR, lots of people there. And yes, it still is true that you want to be close to the probe. The probe goes into the patient's mouth, so you're again close to the patient. Distance is your friend, so every inch that you can step away from the patient and still have control of the TE probe is the lesser the amount of radiation you're getting at this point. I think the room configurations are still pretty similar.
All right.
We are using radiation pads and additional shielding, getting good quality lead to protect ourselves.
All right, great. And then, Steve, do you have a comment, or Bill? I see both of you up on the screen.
I was just going to say that, the dogma is, see one, teach one, do one. This was a very nice case of do one, teach one. We didn't get to see one first. So the remote teleproctoring worked out really very well, that all of us sort of learned on the job in this case. It was confusing to try to understand what we were planning to do, but this was a very nice fusion of echo and fluoro being used side by side with some CT for planning. So unfortunately, no PET in this case, but the other modalities were very critical. So it was a great case. I hope we do more of them, and I hope we can get our imaging fellows to be as involved as possible in these cases, because we all learn a lot when we kind of forge new ground and try new things, and you find out what the limits really are. And I think this case nicely highlights, where we are with the limits. They're disappearing.
This is amazing, and congratulations. I mean, I wouldn't have dreamt of this one being done like this, and it's I think you have the tools and you have innovation on top of that. So amazing what you could do nowadays. And I think this one was published too. So congratulations for a great team.
Was
and
accepted
remote proctoring.
either Jack or Jack interventions in about 3 days. It was very quickly accepted.
Wow. Great. Well, excellent. I want to thank all of the presentations, the fellows from today. I think one very nice, high quality, interesting presentations. And importantly, I want to thank all of the graduating fellows. I think we've all enjoyed having you here for the last couple of years. I think you've all done a tremendous job, and we wish you all tremendous success in the future, which I know you are going to achieve.
Thank you.
Thank you.
Thank you, and we'll see you everyone again next week.
Congratulations, everybody.